Final speaker for this session is Rod Whiteley. Rod will talk on the rehab of hamstring injuries. Now, Rod joined Aspetar in 2010, and I know he's passionate about at least two things, and that's the irrelevance of p-values, yes, and he's passionate about good outcomes for patients. So I'm really looking forward to the final talk of the session. Rod.
Thanks very much, Paul. And I know everybody's keen to get off to lunch, so I'm going to try my very best to keep to time here. Tragically, I can't tell you about any financial relationships I have. I don't make any money except for what I get paid by Aspetar to look after our patients. What I want to talk to you today, as you can probably figure out here, is preventing, predicting and treating patients, but since prediction's really been covered, we'll concentrate on prevention and the treatment model that we've adopted at Aspetar. The easiest kind of hamstring injury to treat is, of course, the one that never happens. So hamstring injury prevention is key. And if you take one thing out of my talk today, you want to get your athletes to do the Nordic hamstring exercise and make sure they do it properly. Doing it properly means making sure that you get them to do the right number of these exercises across the right amount of time. You have to go and look this up yourself, but they need to build this up over a 10-week period. Talking about what we've done with treating our athletes, we're getting, we think, pretty good results from our program. We can certainly improve, but we're going to present to you today some elements of the program, but I think more importantly, how we arrived at this program. Because I think there are some things from the mechanism that we use to create our program which you can probably take across into your different treatment approaches in your different categories of injury. So firstly, why are these exercises so important? If you've never had a hamstring injury before, getting your athletes to do this will reduce the injury rate by 60%. And in those guys who have had an injury before, you only need to treat 3 of them to prevent 1 hamstring injury. More recently, we were going to demonstrate this, but we're running a bit short of time. We have one of these devices up here which will actually quantify exactly how much load is going through each leg as people do these kinds of exercises. And so we can see the side-to-side imbalance between them. We can watch as this tracks up and down. And if you're interested in this stuff, I'd encourage you to chase up Nickel van Dijk, who's busy videoing and tweeting his way across there, whose PhD is at least in part on looking at this and comparing it to other methods of measuring hamstring function. Unfortunately, why this is so important is that even though the evidence is so strong that Nordic hamstring injuries are important, these exercises are not being done. About 83%, at least only 1 in 6 teams are doing this exercise despite the fact that hamstring injuries are such a big deal. And we get a few different reasons as to why it doesn't happen. Some people will say it's not important, the exercises don't work, or these exercises hurt their athletes. And I think all of these are wrong. You do need to do this because if you look after a football team, you're going to see 1 or 2 of these injuries in your team every year. There's been this argument that because it's a 2-leg exercise, slow moving, knee dominant, and that's not how running works, that in theory these exercises shouldn't work. Well, my argument to that is don't bring your theory to a data fight. These exercises work. And they work by a substantial magnitude. As we said, you only need to do these exercises on 3 athletes with a past history of injury to prevent a hamstring injury. To compare and contrast, if you want to prevent an ACL injury, you're going to need to apply that to 90 athletes before you prevent 1 of those. So what you should be going back and telling your coach and telling your owners and telling management is that at the end of every year, look how many hamstrings I prevented. We often don't count these injuries that should have happened that didn't happen, but that's the way that we can get buy-in for this. Now, the meat of the talk, we're going to discuss how we developed and the results of our criteria-based as opposed to time-based hamstring So far, we've documented the outcomes on about 150 of these. They get back to sport in about 21 days, and we're getting about 7% recurrence, as Dr. Toll talked to you before. So a guy who gets injured here on the 3rd, we can say that he's going to be ready to play on the 24th, more or less, and we're going to get a recurrence in about 1 in 20 or so of those guys. When we thought about how we might progress these guys through the different stages of our rehabilitation program, traditionally what gets done is, well, we'll do this for X amount of days, and then we'll do this for another week, and then we'll do this for a different amount of time. But the approach that we took is, we said instead we really want to go towards criteria-based. And why we take that approach is, we said that at the very end stage, we know what you need to do. We can tell you what has to be done to play football, but before I let you do that, I'm going to make sure you can do one step less than that, and one step less than that, and so on and so on. And we're happy for you to move through this criteria-based progression as fast or as slow as your injury and your body dictate. What that does mean, though, is you need to constantly measure what the athletes can and can't do at every stage of their rehabilitation, rather than blindly following a time-based protocol. So the broad overview of our rehab protocol is that we spend some time in traditional physio and some time out on the pitch, and we have 6 different stages across those 2 settings, although it's a little bit misleading here because almost all of the rehab happens in these 3 stages. Typically, these last 4 stages only take 3 days. How we arrived at this, and this is, I think, the clever thing that the guys in our department did, was when we were sitting down to figure out what kind of things we could do for treatment for all of our guys, we put up on a whiteboard every possible treatment that everyone wanted to do, and then we rearranged these in order from what we thought was the least stressful for a hamstring injury up to what was the most stressful. And in fact, there were a bunch of other things on here that I didn't put on the screen just because it's too hard to read. Then we thought that that fell into 3 separate groups, so that all of these kind of things were more or less the same amount of load on the hamstrings, as were these. And then we tried to figure out, well, what would be a predictor that says you can move from this stage out to this stage, and that's how we developed our criteria, which we've since continued to refine. A key part of our rehabilitation is that from stage 2, and typically this will be within 1 or 2 days of us starting treatment, our athletes start running. Almost all of the hamstring injuries that we see are running related, and we think the most specific exercise for hamstring injury during running is running. So we have to monitor the volume, intensity, and in particular the mechanics of how people run during their rehabilitation. Key to knowing exactly what the athletes have to do at the end when we're going to discharge them is how much running, and especially how much high-speed running they're going to get back to. We're talking about football today, but we'll take this example from Australian rules football, only because the data's a little bit better documented, where when we think about higher speed above 20 and sprinting above 23 kilometres an hour, across the 4 quarters of a game, the average player does 4 minutes of high-speed running. So you might think, well, all we've got to do to get them back to an average demand of the game is get back to 4 minutes of doing this. But that's an easy trap to fall into. By definition, if we only get back to the average, we're under-prepared for half of the demands that they're going to come up against. If you want to be ready for 2/3 of it, you need to do 6 minutes, 1 extra standard deviation, or 95%, we've got to get up to 8 minutes worth of high-speed running to come back and play in Australian football. You can do the same thing across distance, and it works out to be the same way. It's just doing it by distance turns out to be a little bit easier to document within your clinic. And that being the case, we need to be able to do 3.2 kilometres of high-speed running before we can prove that these guys are going to be, well, we think, durable and safe to return to play. We've talked about one sport. How applicable is that to football? It's not. You need to document the same thing in football or whatever sport your athlete's getting back to. And you also need to consider the level within football. And here's some football data. we know that at the highest level compared to one step down, they're doing approximately half as much again sprinting, professional players, compared to the lower standard. And finally, within that sport of football, different positions, of course, will have different demands. Obviously, goalkeepers don't do an awful lot of sprinting, but it turns out when we compare defenders with midfielders and strikers compared to all of them, while the defenders might cover a lot of distance, they don't cover terribly much at high speed, certainly not in comparison to the midfielders and strikers. So we really want to tailor our rehab to what these guys are going to do. The last little bit that I'd encourage you to have a think about is exactly how these guys are running. We'd always thought that this was an important thing for us to pay attention to, and there's some recent, not strong evidence, but there's some evidence that there are mechanical changes in the way that guys run after they've had a hamstring injury. What these guys looked at was a bunch of people who had a hamstring injury and returned to play, and they looked at the side-to-side asymmetry compared to people who'd never had an injury. And they looked at it in terms of sagittal movement of the pelvis, lordosis compared to losing that. Also at the hip flexion and extension, and finally at the knee with the amount of rotation. The net effect of it was people who'd had a past history of hamstring injury run with an increased lordosis, with more hip flexion and more internal rotation. You've all figured out that doing all three of those things is the best possible way to place more tension on the biceps femoris muscle. About 80% of hamstring injuries happen to the biceps femoris, so it probably stands to reason that we want to try and redress this during our rehabilitation. So what do? During our running, we also try and pay attention to retraining both this late swing phase as well as the stance and acceleration phase of running. But in particular, we want to progress up from walking to jogging out to running. And over in our clinic, which hopefully you've probably seen now, we're lucky enough to have this indoor track where this distance is about 30 metres thereabouts. So when we get them during our rehabilitation to do about 4 laps, that becomes 8 of these 30-metre sprints. So that's about 8 30s, 240 metres each time on each of those sets, and we make them do typically 3 of these sets. Every time they run from the start, we ask them to run at the slowest possible run that they could, to rate how fast they're running, right up to a full sprint. And we get them to progress that according to how their symptoms dictate, and at the same time we confirm how fast they're running by timing them. Once the athletes tell us that they're running at 70% of their maximum, we start to institute direction change across a T-test course. Now we do it a little bit different to what you probably know as a T-test, where everybody stays facing in the same direction. Because we think landing and changing direction is going to force a little bit more stretch on the hamstrings, we actually make these guys hit the ground, reach over, touch the cones and change direction. So when these guys run that T-test, they're in fact going to run up and around. Any second now, this is going to work. Yeah, there we go. Up, around and come back. The fastest of these guys will end up doing that in about 9 seconds when they say that they're running at 100%. So back to each of our stages. In that very first stage, we don't let them start their running until they prove to us that they can do a standardised single leg squat and that they can ride the exercise bike at 1.5 times their body weight, so an 80 kilo person, 120 watts, and they can do that for 5 minutes without any pain. Using those criteria, so far, we've never had somebody who's not been able to do some running painlessly. As mentioned, once they can run at 70%, we start direction change and eccentric exercise, although we now think we should be starting that earlier. And once they tell us they can't possibly run any faster in a straight line or on direction change, we send them out on the pitch to work with our sports rehabilitators who do a very hard session as the final clearance to play, a very light session and one in between. Individually, to try and progress within those stages, we take a range of clinical, subjective and objective measures which came out of some analyses that we did. We take these measures every day, and if the athlete is same or they've got better, then yesterday I didn't push them hard enough. If they're worse, I push them too hard. So every day we're trying to change what the athlete's doing and pushing them as fast as we possibly can, but not too fast. And we never ever get this 100% right. There's a bunch of different things, of course, we could be measuring each day, some of which are listed up on here. But it turned out when we plugged all of these things into a bunch of different analyses, a whole bunch of measurements of strength turned out to be important in predicting if the athletes were going to do well, 2 subjective measures, and a couple of demographic features. So these are the things typically that we'll measure from day to day. It was really of interest to us, and might be to you clinically, that when we took 3 different kinds of strength measurements, we call this one inner, mid and outer range. When we look at our typical patients return to play over 21 days, this measure, which is probably what gets done clinically the most, normalises to 100% of the other leg very quickly. The mid-range measure takes longer, typically around 2/3, but this measure down the bottom here is the one that tracks closest to the athlete's recovery. Same athletes, remember. So this is how we measure our guys every day. This would be 10 days worth of our notes, and if we look a little closer at one day, we're now only measuring the things that we think actually count, and within this, the ones that count the most are, how much pain do you have? We palpate and see how many centimetres in length the pain is of their injured area. We take 2 strength measures, but as you saw, we pay more attention to this one and one particular flexibility measure. So your take-home messages. The sooner you start the treatment, the better. Every extra day that people delay to start treatment in our model added 3 days to how long that these guys had to get better. We've got a bunch of different things that you would want to measure there clinically. The other things aren't so useful. These are the ways we measure and look at each of those different things. And I'd really like to thank the team who did all of the work here with this, some of whom are shown up there and the rest of them are off working clinically today.